Dan, actually, you'll be happy that the SIB stuff does get covered here. So it is fun. Okay, so at the beginning of this, I'm talking to the, right? Okay, at the beginning of this, you guys were explaining why you do research. And so I started trying to think about why I and I think there's 3 reasons. One, I grew up in a household with a guy who was a pediatrician, my father, who never spent a day in clinical practice, yet still considers himself a board certified pediatrician. And he studied tropical medicine and malaria, and he basically would tell everyone, or that's what I grew up with. And so it was like my internship year when I realized suddenly that people just continue to see patients in clinic and take call for the rest of their lives. It's a little bit of a shocker to me, but maybe I should find something else. 2, when I went to the Navajo reservation, I think I sort of fell into this issue of child abuse and neglect because no one else would do it. I was fascinated by it. I realized that I had enormous about what we did. I wasn't ever quite sure that we made it better for people at a global scale. Obviously, one patient here and there, you know that you've made a difference, but I think there's still a lot of uncertainty. That they feel like everything's been studied. I promise you it hasn't. It's just hard to get there. And so I think maybe unlike Dan, who sometimes has enormous certainty that I really am jealous of, I am characterized by uncertainty. So one of the things I've been doing is working across disciplines because I feel like our area in child abuse pediatrics is actually somewhat unique in medicine because our treatment for our patients is outside of our control. If I diagnose a person with leukemia, I can refer them to my brother. And as bad as that relationship has been over the years, we were just explaining things that we've done to our siblings, Dan and I were discussing, he would still write me a note and tell me what happened. That is not always true when you've referred someone out to law enforcement or child protection. So I'm committed to the concept of interdisciplinary collaboration in this field. And it's difficult, and this may be as much a discussion of how I failed as a tiny little success I've had. And I'm not advancing. Enter. There we go. So I do believe that this meets the that child maltreatment research does meet definitions for a wicked problem. And if anyone hasn't looked up the definition of wicked problem, it's sort of a fun thing to run through. But basically, there's no definitive way to describe the problem. There's no clear rule for knowing how to fix the problem or stop your investigation. Each single one of these problems is unique, and I think we all experience that. Each is a symptom of another problem, and we definitely agree with that in child abuse. Each one solution is one solution. It doesn't mean it's going to work next time, and that can be extraordinarily frustrating. And unfortunately, there's never just an easy alternative solution. Those are sort of classic definitions of policy issues that are described as problems. In addition, the solution really depends on how you frame the problem. And this is where interdisciplinary research comes in, because each person on your team and those multidisciplinary teams frames the problem somewhat differently. And the stakeholders each have a different frame, and it can be extraordinarily hard to step outside of your frame. And I would encourage you all, as you're running through your training and your research, to think about this. And approaches to wicked problems that are proposed are authoritative. One person decides everything. Competitive, where you have each person sort of, or each group, stakeholder group, sort of vying to take the lead on something. Or collaborative. Most people agree that collaborative is best, but in the world we live in, not always, but that I'm going to go with that. Okay. So this may or may not inform, it just helps me sometimes frame what I'm thinking of. And I think that as I've read more about this, it's helped me think about some of the problems that I run into both in research and practice. Despite this, the current approach to child abuse has been described by the Commission to Eliminate Child Abuse and Neglect Fatalities as reliant primarily on a single government agency, meaning child welfare, to intervene with families who face complex and intersecting challenges. And they did challenge all of us to step outside of that framework in terms of thinking about how to address some of the really critical problems in preventing child abuse fatalities and near fatalities. So in terms of why I do research, it's, you know, there's that statement where it takes 17 years for scientific advances to translate into practice, unless you're Dan Lindbergh, in which case it takes about 4. And that's really for solutions to problems like cancer or heart disease, where you're talking about a single setting and a single framework. The science of child abuse and neglect has to be adopted across multiple sectors to advance change, and research in child abuse and neglect has to reflect that interdisciplinary nature of the problem. And so I sort of believe that collaboration and dissemination is going to lead to action. And if we all stay within our own frameworks, within our own specialties, within our own disciplines, we're going to lose that. And I like that this particular group has such a diverse set of people entering the field, and I would push you guys to hang on to that. Don't believe that like then you get into your group 1, group 2, and I know group 3 was out there and got collapsed into others, but view all of the folks you're meeting are your colleagues, even if you work in different buildings, in different places, and things like that. And so for examples of this, and examples of little projects and little ideas that then can spread through a process of dissemination and collaboration, I wanted to present a few different projects that I've worked on over the last 10 years or so, and how they've grown, how they've succeeded, and where they've fallen absolutely flat on their faces, and see what you think. So I don't have any grand successful randomized controlled trial or a huge database to present you with, but we'll see how this goes. So one of the things I started with when I went to University of Pittsburgh, and Rachel Berger and I were sitting around talking, she said, you know, I don't know what to do with siblings. She had a couple cases of bad situations with twins who had been more seriously abused than the one who presented to the hospital. And, you know, what are we supposed to be doing? And so we started talking about it. And one of the problems was that there was this scapegoat theory. And historically, if you look back in the literature, there tends to be this idea that one child in these families, particularly in sort of the classic battered child publications, one child bore the brunt of the abuse while the siblings were extended the best of care. The beaten infant had something about him or her that made them different. They were an unwanted pregnancy. They responded to parents differently. Helfer wrote about one child who was felt to respond differently. Or the idea that there was something about the child's own behavioral problems or attitudes that might have made them a focus of maltreatment in the home. And that was sort of what we described as the scapegoat theory. Now, at the same time, you had the ecological theory of Bronfenbrenner, which said, no, these kids live in this system. Like, there may be something about a child, but they live within a system that prescribes risk or not to them. And in that situation, we really need to think about all of these children in a setting together that share risk. And so Rachel and I wanted to think about this a little bit. So so really what we went, and in a very simple fashion, asked was, do we, meaning child abuse pediatricians, believe in scapegoats or environments? And what is the recommended medical evaluation for siblings of children with suspected physical abuse? It's a fairly simple survey. I was in fellowship. I could get it done. We also did a chart review of siblings of children who had been seen by the child abuse team at the University of Pittsburgh. But basically what came out of it is, this is going to come as a huge shocker. Child abuse pediatricians always thought that everyone should get a medical exam. I mean, pretty much. I mean, you can bill for it, you know they're there, it's super exciting. Like, we all wanted to see them. This was not, it was actually published in a really good journal. People thought it was awesome. I'm not sure it was that surprising. Like, we even, so I gave these clinical scenarios of a 1-month-old twin who had abusive head trauma. And then there was so there's the twin, and there's a 19-month-old and a 12-year-old. And I did what I was supposed to. I pilot tested the survey. I sent it out to other fellows because they couldn't be in my survey sample. And they came back with suggestions, and we figured out the best way to distribute it by mail on fancy, heavy, it was on good paper, but not the fanciest heavy paper. There was a problem because my CVs were going out the same time on fancy, heavy paper. But caused confusion for one person. Anyway, and we got back the requisite 60%, and it went out, and it was the first time someone had really sort of tried to figure out what we should be doing with these kids. And it sort of looked like we should be doing skeletal surveys on them, we should be doing neuroimaging, and we should be doing medical exams on lots of them. I'm not going to present the details because that's not the interesting part. But so then someone named Dan Lindberg came up to me at Helfer and was like, I loved your study. And I said, I have no idea what you're talking about. And he said that this was really cool. I want to do this big multi-center study of the prevalence of abuse-related findings in siblings. And I was like, oh, wow, okay. And, you know, that was cool. The problem was actually that my particular clinical group that I ended up in would not agree that what he was proposing was standard of care. I'm not sure how I felt about it, but we couldn't as a center participate in the extra study, but he went ahead and he did it, and it was really great. So we started with sort of this small little survey project. Someone sort of started moving forward with it, thank you, Dan, and said, let's actually figure out what the prevalence of abuse-related findings in these siblings are based on the expert consensus that you got from we could call it a consensus, from your survey. And lo and behold, he did a study. And when we looked at the 0 to 5 years of age kids who got medical exams, he had 355 of them. Most of them had medical exams, not all of them, but most of them. And about 6% of them had positive findings. You can assume it was somewhat higher than that if you include the ones who didn't get an exam. Maybe 6% of those also had findings. And then of the 0 to 2-year-olds who got skeletal surveys, again, there was some that didn't get their study done, but of those that did, 12% had positive findings. And, you know, that falls fairly well within sort of the range of things we do invasive studies for within medicine. And so people started to say, like, okay, well, maybe we should really do this. And it's been shifting more into standard of care at a pretty rapid rate, which is nice. But so an interesting question is, when you look at the recommended medical exam for siblings of children with suspected physical abuse, how do you get those siblings in? How do you identify them? And actually, that's not necessarily within medical practice. I mean, we can talk to families, but a lot of times that's going to fall to child welfare workers and CPS caseworkers out there in the field. And so someone came to me and said, well, we want to do this like adaptation of that survey that you did in your fellowship, and we're going to give it out to caseworkers. And I said, oh, okay. And so they started to do that. And then they said, actually, why don't you try and do it in Utah? And I said, well, that's a great idea. And so an interesting finding was that there was a substantial disparity between what we had found in terms of physicians recommending medical exams and what caseworkers said that they would recommend. And, you know, it got played up a little bit as like, well, caseworkers should be doing at least the way I heard it was caseworkers should be doing what doctors say because we know what medical exams are needed. The reality, though, is that when I took this survey to my CPS, my child welfare office downtown for the state, they would not approve the survey because they looked at the survey and they said that survey makes no sense for caseworkers. Now, the people who did this study, this is in no way sort of calling them out. We've had these conversations. They were already started with the survey. They didn't have a group that was quite as didn't have such strong oversight over the research of their caseworkers. But the questions meant something different to caseworkers. Caseworkers were like, well, it's not my role. I can't recommend medical exams. They were very clear that this didn't make sense for them. There's also practice realities, which is that caseworkers don't feel like they have that level of control over families. They're just barely trying to keep everyone in and talking at the same time. And then also there's an attitude and a knowledge base, which is that when I talk to caseworkers, even today sometimes, they're like, that's funny. We thought it was this sort of scapegoat thing. And I say, well, you know, actually, I think there's pretty good evidence that that's not the case. I mean, it happens in some cases. And so there's a different knowledge base, a different attitude. And the reality is, who reads pediatrics or archives of pediatrics and adolescent medicine, which is where a lot of these articles came out, and who reads or learns from other sources. And so it showed me that we really need to do a better job of disseminating our information across disciplines and across sectors. So how to translate findings, because in order to have meaning for your research, I came from a public health household. I do research that has public health implications, and you need to disseminate your information to key stakeholders, finding champions who think like, hey, I'm going to take that on and move forward with it. You want to find those folks, but not just talking within your own echo chamber. You want to develop new practices and policies. You want to get yourselves on boards or community advisory boards or oversight boards or whatever they are in your state that are going to help to push the practices forward to reflect how science is moving, and also though to listen when someone says, no, that doesn't apply to our setting, because it might not. And you want to identify the facilitators and barriers to change for those new policies and practices. And then in the end, something that I'm still learning to do is you want to measure change, because you can make all the practices and policies in the world and it may not change practices. And you want to also, when you're measuring change, consider benefits and harms. Is it causing more problems? I mean, great, you found more kids. Did it help? Or did it cause more problems within the system? Did caseworkers feel increasingly overburdened? Did families face impacts that you didn't consider? And so you want to be open to listening to accept, to accepting that you may be causing harm, or that you may not see the results that you thought you would, despite how brilliant you are. So what we've done is, I sit on one of these community advisory boards for the state, and it took all this negotiation, and we wrote up a really cool medical consultation protocol when there's reasonable suspicion of severe abuse that basically says, and there was lots of negotiations. They actually changed some things that I thought were really brilliant. Instead of setting ages, they said it needed to be for nonverbal children. So they've been really good. And I have to say that it seems like this is working really well. Most of those kids who have severe abuse come to our center. We see almost all of them in the state. The caseworkers have strong relationships with us. So for the first 6 months, my team would just go like, hey, there's this new practice policy. Can you bring, make sure we're going to see the siblings? And they were doing that. Having said that, we have not objectively measured our outcomes, even though I told you you should. And so it might be a nice study to do someday. Anyone want to come up with a study? We could do it. Oh, Dan! Talk to me after. We could do this study. We can get the data and we can look at what it's doing, at least within child welfare data, and whether they're really seeing those kids and identifying them the way they're supposed to. It might be disappointing. Sometimes their data isn't as good as I want it to be, just like sometimes administrative health data isn't as good as I want it to be. But it's worth thinking through. There's a lot of different study questions. I want to know, did they find abuse or not? Did they do the medical exam the way they were supposed to, or they didn't? And there's a whole list. It may be that my colleagues in child welfare have a different question. How much extra time did it take my caseworkers to get those kids in? What are the different feelings about those families than other families if we had to lay them over the rack and say, you better get your kid in? And did it result in anything different in terms of the interventions they would make? We may have different questions, and I would recommend that if you undertake a study like this, or if I do, or if Dan does, we need to go ahead and make sure that we're asking questions that are relevant to us, but also relevant to our colleagues in child welfare, because ultimately that's the only way it's going to matter. I'm not saying ignore what you want to find out, but work with and across. Okay, the second series of studies related to the communication challenge, which I think is something that people have heard about. And this was coming out even when I was working on the reservation and didn't know what I was going to do with my life. And one of the things so Emily Flaherty, who was working out of Chicago at that point, well, she's retired. And she did this series of studies that I just always have really liked. I thought they were really elegant and nicely sort of planned out. And what she started with was sort of asking people well, so what is your experience of working, of making referrals to Child Protective Services? She was asking outpatient pediatricians in that PROS network that Dan mentioned this morning, although I don't remember, that was in our small group, sorry. But a network of outpatient pediatricians that do research, and was sort of asking them questions about what were their experiences making reports to child welfare. And one of the things that sort of always rose to the top was it disrupted my relationship with my patients. I wasn't really sure if families benefited that much. You know, and there was sort of this agree versus disagree, but it wasn't a real strong, like, yeah, that was definitely the best thing I ever did for that family. And then I think yeah, okay. The physicians that commented that reporting suspected abuse to CPS forever changes their relationship with families. And this was a quote from one of her other studies, her follow-on study. The physicians said that their experience with CPS was a potential barrier to reporting suspected abuse. Some physicians were discouraged and disappointed that they did not receive more support from CPS. When CPS did not follow up on the physician's concerns, the physician felt exposed. Physicians indicated that they did not always receive feedback from CPS after they made a report. And this is something that, you know, given the timing of this, I don't know how strongly people felt about it before Emily wrote this, but I certainly have felt it since then, and it's something you hear over and over. Physicians say, I just never know what they did. I don't know what they said, okay? And then she went on to look at a much larger sample size. She basically looked at whether people were reporting injuries that were suspected to be related to abuse. And she could find a number of cases in which people would say, like, yeah, it could have been abuse, but they chose not to report it. They sort of actively chose not to report it. And these were when she did the analysis, these were the factors that rose to the top. They had previously lost a patient that they had reported to CPS because of abuse. They had never had the experience of reporting it. And then the things that helped were like having had prior cases. So clearly prior experience with CPS had made a big difference in whether people chose to make appropriate reports. So when I came to Utah, I was, you know, I'm still thinking about these things, and I thought they were really interesting. And one of the things that I did was I talked to my general peds. I still work in a general peds clinic, and I still interact a lot with general academic pediatricians. And they had a whole program going where you do learning collaboratives, and, you know, you learn how to take care of asthma better, you learn how to screen for autism better, and you get continuing medical education points for it. And it's, you know, it's good. And they last, you know, it's not just single shot things. They last for 9 months or so, and you go to several different day-long learning events. They have an acronym that I'd love to, you know, get some feedback on, which is really complicated, the Utah Pediatric Partnership to Improve Healthcare Quality. And they came up with UPIC, but, you know, it works really well. And I said, well, so why don't we have, like, I mean, if you're talking about collaboration, let's have a real learning collaboration. Let's teach healthcare professionals about CPS, but then also teach child welfare professionals about things like medical homes and what does that mean? I had a really funny interaction with the guy who was the director of our child welfare agency during one of my first years as a faculty member. And I came to him with something like this idea, and I was talking about medical homes. And for those of you who aren't pediatricians, that means you go and you see the same pediatrician the same time, or each time, and you know that person and you have a relationship with them so that they know your children, they know your family's needs and wants, they know your sort of your expectations for care. Works really well, especially in children with special healthcare needs, but probably works really well in kids who have special social needs as well. Anyway, I was talking to him about medical homes, and he finally stopped me and said, what's a medical home? And I was like, oh, yeah. It was one of my first introductions to, we're speaking a different language here. And what was also funny was he emailed me over the weekend. He's like, I took my kid in for strep throat, and there were all these signs about medical homes all over the building. He was very proud. He knew what that meant now. So I thought, and then we should teach everyone together, like in the same setting, about child maltreatment, about social determinants of health and toxic or traumatic stress. So they thought this was a great idea. We wrote for some money. We recruited some child welfare administrators to come and sit on the planning committee. And it seemed like such a really good idea. We recruited 9 pediatric practices in our region to come do this. And there was one child welfare office that was told that they were going to come and participate. We had 3 half-day learning sessions over 9 months. There were in-office quality improvement coaches. We had the introduction, and then every group, including the child welfare group, was asked to start screening their patients or clients using either the SEEK questionnaire, which is Howard Dubowitz's sort of a, not quite, but sort of a social determinants of health screener. And that's what the CPS group chose. And or the trauma experiences questionnaire, which there's a whole nother story to that. It's not, it doesn't really exist. Don't use it. But it was going to exist. It was supposed to, anyway, long story. But people are always like, can I get it? I'm like, no. And then if you answered yes, that you had had one of these traumatic experiences, you went to a series of trauma symptoms. And clinics and child welfare providers were given information about how to respond to each of these questionnaires. We also made 2 relatively large practice changes for our child welfare group, which is, first of all, I don't know how we got them to agree to this. So we have a statewide intake office, and then they just route things to sort of the geographically closest place for the family. They agreed that if a CPS referral came in from one of the practices, they would route it to the CPS office that was working on this project. And the second thing that came in a little late, but was a long negotiation, was that they would provide a case closure letter to medical reference involved in this particular learning collaborative that gave meaningful information. Like many states, our state sends reference when they close a case, a letter that says, "Dear so-and-so," or dear person, "Thank you for referring case number 24872. I can't tell you anything, but we appreciate your concern for your community. Sincerely, your child welfare worker." And I've explained that actually I would much prefer that you not send me that letter, because I really, it just makes me angry. And so instead, they started writing letters to reference saying, "Dear referent, we investigated the case of Bobby. We found the following," and then they get a list of sort of, it was substantiated, not substantiated, and then risk factors we identified and referrals to resources that we made. So still nothing hyper detailed, but meaningful information. And so that was viewed as, it was basically a loophole in the law that people had never recognized. It can only go to medical reference. It didn't require changing the law. Anything else would have required changing the law. So those were the things we did. So there were a few early issues, which I'm sure people smarter than me could have guessed. One of them, professional cultures aren't the same. Does anyone know what a PDSA cycle is? Plan, Do, Study, Act. Huddles, things like that. So this is quality improvement in a medical setting. And at least the way I'm taught to do it is that, like, every week you get together in a little huddle and you say, okay, let's look at our Excel spreadsheet, find out how this asthma tracker worked. Were we doing it well or not? Let's just change things up this week. Guess what? That does not work for CPS caseworkers. There is nothing that would allow them to do that. There is no cultural tradition of just like randomly changing it up. The legislature wouldn't like it, as far as I can tell. So that doesn't translate well, and that was the only thing that the UPIC learning collaboratives really, like, that was how they operated. They were always like, come on, do your PDSA cycles. So that was challenging. Old hierarchies are hard to break down. Guess who sounded like they were the boss at every one of those learning collaborative days? That would be the doctors. And guess who seemed to feel like they were just maybe supposed to do whatever the doctors said? And that would be your child welfare workers. And I kept trying to change it, and I couldn't figure out how to change it. I wasn't the boss in either setting. I was just the facilitator. It didn't work very well. And the other thing is, big bureaucracies are very hard to break down. We talked about that letter, and we're so excited about that letter. I think we started talking about it 3 months before the Learning Collaborative, and it finally got agreed to by all the lawyers about 2 months before the Learning Collaborative ended, so almost a year of negotiation. So it's just hard to change those. The other thing is that child welfare administrators, the folks who were sitting on our planning committee, are not child protective caseworkers, right? They're not CPS caseworkers. And they know that. I'm not saying they're doing anything wrong, but they have this greater vision of what could be. And CPS caseworkers have a greater vision of their workflow for the day and how they're going to get through it. They were volunteered or voluntold to come to this project. They did not actively sign up the way that all of my 9 pediatric practices did. They were told they were going to come, and so they did. But the first day I was sitting there, and it wasn't even a caseworker, it was a regional supervisor, but still somewhat lower on the totem pole within CPS. And she just looked at me, she's like, I don't understand this at all. Why would a doctor want to know anything about a CPS investigation? And I was like, oh, wait, there was a first like initial stepping stone that we really needed to overcome. And so I think, thinking about how to translate these activities and make them work and meaningful for everyone is really important. So I did I did an evaluation of this, and I evaluated my question, which was, what was this like for everyone involved? Now, there were some other people who started other evaluations and they've never written up those papers. That's okay. Mine literally just got published. And it was a few years ago now. But my question was about experiences. We could have done the question of how many pediatric practices changed their screening programs and what did they pick up and things like that. That wasn't the question I really wanted to answer. So I went with a qualitative question. And I will say that the first review that I got on this, it wasn't the reviewer's question either, because I kept calling it a quality improvement project and he wanted my run charts. And I was like, oh wait, I say he, that person wanted my run charts. I was like, oh wait, I didn't explain myself well enough. I took out a lot of the quality improvement language and it worked out okay. But, so there are always more studies you could do. So I looked at the Learning Collaborative participants. I had 4 different groups: the caseworkers, the administrators, the clinic staff, and the clinicians. These are all studies you could do during a fellowship, probably faster than I did. We did a phenomenologic approach, which means I did not make any attempt to develop grand theories as to how this worked or anything like that. I wanted to know what it was like to work in a collaborative group like this. The data was a focus group. We just did focus groups, and we wanted to, and that was an active decision. I've always really just done interviews when I've done qualitative research, and this was to encourage crosstalk between participants, which turns out to have been really helpful and the right decision in this case. But we chose 4 ones to try and reduce the impact of hierarchical suppression. We didn't want clinic staff like the nurses and the MAs to have to deal with how the physicians were thinking, and we didn't want caseworkers to have to worry about the administrators. We only had 2 administrators, so it made for a somewhat funny little focus group, but we got 100% participation from them. So it was good. And then we did a lot of iterative reading, coding, and rereading, interrupted slightly when one of the key co-investigators changed jobs, and there were a variety of problems. But anyway, so the experiences were that people have different ideas, and I think that these actually speak to not just this learning collaborative. This is to any time we're talking across sectors about child welfare issues. And so this physician was like, I think we should be using CPS services more proactively to help families and reduce risk and reduce stress, rather than only when there's already been injury, which was a little funny, because if I had put another quote from a CPS caseworker up there, it was basically like, these doctors call and they think we can do everything, even though there's not been an injury. But whatever. And also the idea that people don't know how, that there's messages being transmitted between these 2 groups that don't get translated well. And most literally in the case where physicians say to the ER nurse to get to the ER physician, or to the social worker, and it gets passed down the line till the referral or the discussion with the CPS caseworker seems to make no sense in terms of what they got as their initial referral. And so this idea that the translation isn't working. On the other hand, they felt like this process had really opened up communication, and they felt more comfortable talking across sectors. And so another physician said, previously I thought it was the call of last resort. Now we tend to call them early about families before they're in too much of a struggle. They found it actually really helpful to talk to our intake worker, and we are not a state that has an alternative response, so I imagine many of these cases are not opened. And then there was a funny discussion between our administrators, because one of them was like, oh my gosh, the Seek questionnaire, it's like asking people if they have, smoke detectors, and you guys have no idea what we're walking into. And I was thinking, I didn't know you were going to ask about the Seek things. That's sort of funny. But the other administrator basically said, like, I love this. I love having the conversation because it allows us to say, we're really on your side. We have the same goal to have your healthy kids, healthy families. And it's not that we're trying to walk in and take your kid away. We're trying to make you best parent you could. And he ends the whole thing with like, I'm going to try and get smoke detectors for everyone. It was really funny. And the administrators also said, we've all been working in our own little silos forever. And I wanted to see how we could integrate and get away from that thought process. I think that one of the big things that's come out of this is that closure letter, it really engages the doctors. And so what did I do? I immediately said, that's great, we'll go do the letter. So I did a practice alert. I did the same thing, went to the Child Welfare Oversight Board. I said, can you put this practice policy into place? And now this letter, by practice policy, it goes to medical reference to give them meaningful information to be able to follow up. And I really felt like we were really breaking down walls. We were breaking down barriers between the child healthcare and child welfare providers in our state. And I was super excited. The only problem is that I probably make as many referrals as anyone else in the state or more, because I work in child abuse pediatrics, and I've gotten this letter once. This was enacted in 2016. There's a little problem. So, and that gets into some of my other stuff that's going on now, which is really going to be talking more about how we've moved forward. This is not going to give you results so much, as few as you've had already, but it's going to talk to you about some of the things we're trying to take on, the challenges that we've recognized, and things like that. So I always like this. The first time someone showed, I guess this is a meme now because I Googled it the other night to find the actual picture. Now I know what memes are because I have two teenage boys. Or I think I do. It's similar to confidence intervals. It's probably different every time you define it, but whatever. But I have always liked this image. Someone showed it to me a couple of years ago, and I was like, oh yeah, that's right. So the idea of always trying to see things from multiple sides. So these are qualitative quotes that come from a couple different studies. They're not all aligned, but I think they're not all the same study, but they're all aligned on the importance of having multiple perspectives. So I still have pediatricians telling us the same way they told Emily Flaherty, 10 years ago. I've gotten a letter from CPS saying, thanks for your call, whatever, bye. And they're like, I don't know who you're talking about. I don't know why you're calling me. And then a CPS administrator sitting at a table saying, one of the doctors that we were sitting with in this learning collaborative, that one was the learning collaborative, said he had a family in his practice. No one told him that a child had been put into foster care. And that was an aha moment for me, because I realized, oh, we need to make sure that we're communicating with these guys. This idea that like someone would miss a child if they got placed in foster care, that wasn't something that a child welfare administrator was thinking about. They didn't know someone was expecting the child to come in. And so those kinds of communications are important. But we also, in some other studies, talked to parents. And a funny thing that came out of one of the studies I did is how many parents actually kept wanting, they sort of wanted, but sort of didn't. They kept wanting someone to come back and check in on them after the case was closed. There was this one woman, and it was a really sad situation, but she said, people that have abuse in their families seem to get all this help from DCFS. I hear that from my friends all the time. DCFS does this, DCFS does that. Well, what about the families where there's no abuse left? Because the perpetrator in this case had gone to jail. I mean, sometimes they need help too. She was at her wit's end. She didn't know what to do. And all her friends, because this is not a rare phenomenon, were still getting all this help. And she was like, well, someone should do that. Well, that didn't work very well, sorry. So I'll read that to you, but it says, the other one is that the parent, bummer, sorry guys. Was talking about this with parents. So one parent said, I want to talk about this more with DCFS, and then I'll read this one. Another parent saying that they wanted to talk about it more with their doctor. I mean, he doesn't seem like a really judgmental doctor. I imagine that if he knew more of the whole situation, he'd probably understand. I feel like I would be comfortable talking about it with the doctor if it came to that point where I didn't have to bring it up. I feel like I would be comfortable talking to him about the DCFS involvement. And so we're still running this study, but what's coming out of it is, in addition to saying we wish more people would check in on us after a case is closed, they're saying we'd be comfortable talking to our doctors, but we don't want to be the one to bring it up. So it seemed like bringing together different people from different disciplines to sort of think about how do we help families after the investigation is over was probably a good idea. So we have a little joke. We say a pediatrician, a child welfare administrator, and a public policy analyst walked into a bar but forgot to bring a couple of really important people, one of whom was highlighted in the lecture yesterday, which is someone who knows how to implement things. But that's a different issue. Well, it's not different, but it comes up later. So our question that we've been asking, and this is through Robert Wood Johnson Foundation Interdisciplinary Research Fellowship, is really how do child welfare policies and practices facilitate or impede, this was the first question, child healthcare and child welfare collaboration. And so our public policy expert wanted to look at nationally all of the policies and practices around child welfare around the country and sort of understand what they're doing and whether they seem to be helping collaboration. So we did a mixed methods approach with an emphasis. It started with quantitative, but the emphasis was more on the qualitative component of it. First, we did a national policy scan of CPS regulations around the United States. We ranked them based on whether they were permissive, well, they were non-existent, permissive, or required collaborative policies. We did something that many of you will have been told not to do, which is making up your own scale. Can't recommend it, but it wasn't, and we did not limit this to healthcare collaborations, really because very quickly you realize that very few policies and practices have to do with healthcare collaboration. It's much more focused on law enforcement, foster care groups, and others. We identified 6 high collaboration states and 5 low collaboration states. Unfortunately, 2 of our low collaboration states didn't have child abuse pediatricians, and that was part of our exclusion criteria. So we ended up only with the 3 low collaboration states. We reviewed policies and practices in these states and then did semi-structured qualitative interviews with child welfare administrators, supervisors, caseworkers, and with child abuse pediatricians. Rapidly came to the recognition after doing some initial analysis of the interviews that we needed to also address general pediatricians, and so have just finished that up. The process of this is being published in a chapter. The outcomes haven't been published yet. So the things that we've found just in our sort of emerging findings is that the facilitators for collaboration between child welfare and child health care in all states are co-location of child welfare and child health care groups. So probably folks that work in like children's advocacy centers and things like that are having much more positive experiences. Multidisciplinary teams, and I would say functional multidisciplinary teams, were often cited as one thing that really improved collaboration. The other thing that came out over and over again, and I think that in retrospect has been really important in understanding some of the things that have evolved over the things I've even presented to you before, is the importance of relationships and the importance of trust. Now, barriers to this were power and competition. Who owns that child? Who thinks they know the best thing for that child? And when you have child welfare and child health care unable to reach a decision on that, the collaboration is viewed as poor. Translation, people using language and terms and definitions that don't work, different understandings of HIPAA and FERPA and GIPRA, or I don't know, all the different ones. But different interpretations of what we can and can't share, different definitions of what should reach reasonable suspicion for child abuse. All of these things were cited as problems with collaboration. Professional culture, so people not understanding each other, and political vulnerability, specifically for CPS, the feeling that if you screw up, you're going to get in trouble. And also, you never know what's going to happen next year, and so why bother to make big changes? So, of note, and of some disappointment to the policy analyst who was doing this, they did not mention ever policies or practice guidelines, and we would have to introduce it. We would say like, so we looked over your policies and practice guidelines and we saw X, Y, and Z. And they'd be like, oh, yeah, I guess, you know, whatever. And so like whether they were collaborative or not when we were talking to these folks on the phone looked entirely only like whether they felt like they had good relationships and trust, and looked nothing like, it reflected nothing about the policies or practice guidelines. And so it didn't matter whether you were in one of those high collaboration versus low collaboration states. It was really just based on who you knew and whether that worked for you, which was super interesting. And only in retrospect was I like, oh wait, now I get something, which we'll get to at the end. So, well, no, we'll get to at the end. So that may explain what we found next, which is I said, okay, wait, I didn't evaluate that sibling practice protocol that I put out for you, but let's do this. And so my child welfare administrator, who was the co-investigator on this study, she wanted to look at this. She wanted to say, like, I want to know if this letter that you guys made us start sending out is working. And I said, that's a great idea. I'd like to know if I'm getting them. I didn't say that. I have started sometimes saying it. And so the goal for this study was to do a comprehensive evaluation of all the medically referred cases in the state, how they were using, how CPS was using this medical referent letter, and the variables that were associated with the uptake of this new policy. And we proposed a mixed methods approach. We were gonna this time do a mainly quantitative evaluation, really describing sort of the nature of uptake of this new process, but then also do some qualitative evaluation, talking to caseworkers and to physicians. And yeah, so that's what we were gonna do. We were gonna look at the child case and caseworker variables. We were gonna do some semi-structured interviews. It was a super great study that I was really excited to do. And no one sent letters, so we couldn't do the evaluation because really no one sent letters. There was no place in the database that was, they'd changed the database at some point along the way so that the place they thought they were storing the letters was no longer available to caseworkers. And so you couldn't actually tell whether or not the letters were sent. Anecdotally, after talking to a lot of people, I'm not sure they're sending them. So we couldn't do that study, which was really disappointing, but of interest. I went back and we've talked to people. So the sibling thing, even though we didn't evaluate the sibling practice policy, we all have this sense that it's working. There's just this, I mean, I see siblings all the time. I have caseworkers tell me, I got siblings. This did not happen to me when I first moved to Utah. Like it's definitely happening in a different way. No one is getting these letters. I've gone back to my child welfare friends. I say, well, so what's the difference? Because literally they came out within months of each other. I said, what did you do differently? And they said, no, we did the same thing. We put it out in this mandatory information communication circular that goes out, I don't know, I think once a quarter or something, and just gives everyone updates. And then they send an email to the supervisors. The supervisors are supposed to tell people. She said, and the colleague who's the co-investigator on this project was like, I have no idea why it was different. It doesn't make any sense. Why are you seeing siblings? Because I feel like if anything, we did more for this letter. I was like, well, I don't know. So she went to the supervisor, the state supervisor for CPS investigations, and said, Sarah, why? What's different? And she said, oh, safe and healthy families, which is my group. She said, safe and healthy families is the reason. And I got very offended because one of the things in the sibling component that I wanted to make sure was that it didn't look like we were being super bossy. I actually made them take out language that said evaluations would occur through our center. We're a huge state. That's not reasonable. So I got like, I'm like a puppy dog. I got all like, no, you can't say that. No, it's not safe and healthy families. But what was interesting is what I realized, because Sarah, the person that was telling us this, she said, no, it's not that you guys are being bossy. It's that we know you. And so all the kids who that applies to are kids you're talking with us about. We're willing to take the kids to you, or if you tell us to take them to someone else, we feel comfortable with that. We don't know the doctors that made these referrals to us. We don't know if we trust them to send letters to them. We don't know what they're going to do with the letters. We don't know them. And I was like, oh, relationships and trust. And I felt really good, except I don't know how to write it up. But, you know, so that I thought was really interesting, and I think is an interesting way to explain it, and also has entered the way that I teach and educate now, because I really try and stick, I'm running the clinical clerkship now for our residents, and I make sure that they spend a really solid day with CPS intake and CPS investigators, and I tell them relationships matter. Like, talk to them. I want them to understand who you are and what you do. I know it's not going to change the world, but maybe we need to start thinking about it. And so this was the final study that we did, which was that I had this idea. We're going to introduce a collaborative practice. We're going to engage parents on child health and healthcare through the caseworker. Caseworkers are going to come into the home. They're going to engage these parents. They're going to explain the medical home concept and healthcare. They're going to contact parent-identified primary healthcare providers. And that's so that the primary care provider is going to know that CPS was involved with this family, and that CPS is going to be able to understand if this child is a child with special healthcare needs. And a primary care provider is going to be able to say, like, oh, there may be some social risk in this family. And then they're going to do their CPS investigation. And then in this primary care setting, rather than just who referred the child, they're going to send a letter back to primary care and say, this is what we found, and this is what we've recommended. I thought this was a really cool idea. And the questions that we came up for the study were, can a collaborative practice model improve parent-reported infant health-related quality of life 6 months after a CPS investigation for suspected maltreatment? Does a collaborative practice model change repeat child welfare involvement in those 6 months after an initial investigation for maltreatment? And does this model change parents' perception of what they think of primary care? Do they like their doctor more? Or child welfare? Do they like their caseworker more? We did it in 2 settings. Our state is divided into 5 regions, and we took 2 that weren't involved in some other major event that reflected both rural and urban, reflected over 50% of cases in the state, and we could drive to and do education without spending days in the car. So that, you know, there were a few things that we needed to think about. We wanted to focus on children under 12 months of age, largely because that's when, I mean, let's face it, like, my kids don't go to the doctor that much. Like, children who are teenagers, they're not, like, the idea that a doctor is going to change their life isn't really, I mean, sometimes it's true, don't get me wrong, but you know, young babies are going to be coming in to see their doctors more. We wanted them to remain in the home because that was going to be the easiest way to follow this up and to make sure that we were getting the same reporters. And then it needed to be English or Spanish just because of limitations of our ability to survey families. And so then we had to randomize, because I wanted to do this in a randomized fashion. I thought this was going to be my great experience with learning how to do a trial and a randomization. Adam had $2 million, and I don't know, how much did he have for the implementation project yesterday? Yeah, we didn't have that. So anyway, so we thought about, how do you randomize? Do you randomize by case? About 800 kids per year? No, because then you have to knock on their door and say, hi, I'm here to investigate you for suspected child abuse. Could we go ahead and enroll you in a study and randomize you, please? It's just not ethically possible, doesn't really work. We could do by caseworkers, so there's about 90 caseworkers at any given time in Utah, in these 2 regions in Utah. They're high turnover, they move between offices, gets a little confusing, there may be contamination. So we also thought about, well, we could do offices. There were 13 offices, but you don't know the names of these cities, but anyone who's gone to Utah can tell you that Salt Lake City is not the same as Delta, and American Fork is not the same as West Valley. It was going to be very hard to make those offices look the same, and you could do it by region, but then it's just 2 regions and it's not really randomization. So in the end, what we did was we trained all the caseworkers, and then we explained why we were randomizing, and we randomized 2 to 1 after their training. Now, the reason we trained all the caseworkers is because we were told they would talk to each other, and then they would get confused. So they all needed to understand that this was going on, and then they needed to know, like, am I not supposed to do it, or am I supposed to do it? We got data from DCFS, so all of the DCFS data will be coming into us. We're doing caregiver surveys on all consenting participants, so participants who are willing to talk with us. And then we've also moved now to doing some focus groups to share experiences about this between caseworkers and primary care. And the emerging results are that, first of all, Does the collaborative practice model seem to be affecting much? No, not really. Does the collaborative practice model seem to be changing child welfare involvement? Probably not. We don't have all the results. Maybe it'll change in the last couple months here. And does a collaborative practice model change parent perceptions of primary care or child welfare involvement? Very possibly, but possibly not in the direction we were hoping, which is super interesting. Probably the first question we should have asked is, can you do this? Which is in question, because we're not sure that it really was effectively implemented, which is a huge and unfortunate waste of energy. I mean, it's not a waste. I learned a lot, but it could have been done better. So what I'm going to say is that collaborative research, I have a dog and a puppy. And so really, this is just my begging. Collaboration. They are collaborating, and it is rewarding, it is challenging, and you will at some point get flipped over. I can't believe I did that on time. You need to see each other's perspectives. It redefines the problem, and you need to redefine solutions when you're seeing it from different perspectives, and you really need to work on relationships. And I think that that's probably sort of the special sauce in all this, and I'm hoping to cultivate this more. And so I don't know how much time we have left, but I appreciate the attention, and thank you so much. Thank you.
Any questions for Chris? Well, I think we're ready to go back to the mentoring groups. We do have the, as Campbell mentioned, our has-been dean, that improvement. We'll be meeting the group and we kind of coordinate that. And if there's a big change in that, we know.
That's tomorrow.
That's tomorrow. Right, tomorrow at 4 o'clock. And for a couple people asking, well, what's that all about? And the Fitzsimmons Army Hospital was Western White House for 6 weeks.